everyone, it's nice to be here. So I'm going to be talking a little bit about insulin pumps, a bit of the basics of what they are and why we use them and who's suitable for a pump. Also a little bit about the PHARMAC criteria for funded pumps as well. So let's get into it. So what actually is a pump? Well, essentially it's a device for delivering insulin continuously, and fortunately it's come a long way from its prototype in the 70s and is a little bit more discreet and user-friendly and safe these days. And it's also known as continuous subcutaneous insulin infusion, or CSII, but we tend to just talk about pumping. So basically a pump like this, very small, compact device about the size of a pager. They do come in slightly varying sizes, but roughly this. They deliver rapid-acting insulin only, so either Humalog or NovoRapid, sometimes Apidra, and it's delivered 24 hours a day in very precise amounts, as small as 0.025 units per hour. The rate can be programmed into the pump and then it will just deliver that automatically. So basically this little thing will provide the potential to mimic insulin release from a healthy pancreas. So you'll often hear the terms pump and consumables, and what that means is the pump, and the consumables then are the cartridge, which is also known as a reservoir, and that is what you insert the insulin into, and it comes in varying sizes depending on which pump, which company, ranging from 1.8 mils to 3 mils, and that translates directly to 1.8 is 180 units of insulin, and a 3 mil would be 300 units of insulin. But essentially it goes into a cartridge, and then you also need a line to deliver it, such as this one here, which attaches to the cartridge, and that then is delivered into a cannula, which is usually inserted into the abdomen. So looking a little bit more closely at that. So essentially the pump user will fill the cartridge with insulin. They're disposable, that lasts for about 3 days, and then that is inserted into the pump. Like so. And then if this pump was operating, push a few buttons and away it would go and infuse into the cannula. So the pump user also manually or with a device will insert the cannula into the abdomen or sides or even back of the hips, and that cannula is also changed every 3 days or thereabouts. So that's the consumables. And the options are either the Animas Vibe, which is distributed by NZMS, or the Medtronic pump. These are the two PHARMAC funded pumps in New Zealand, and the Medtronic is the one that comes in 2 different sizes. So the 522 just has the smaller cartridge for people who have smaller insulin requirements, and the 722 is the slightly larger pump with the larger cartridge for people who are on larger doses of insulin. There are different types of cannula options, and I can pass this around so that you can get a little bit more of an idea. But essentially you've got, this is an angled Teflon one, so for the people at the front you'll be able to see the little straw-like cannula sticking out there. So that's what actually sits in the subcutaneous tissue, so that it's introduced with an introducer needle which is withdrawn and leaves behind that cannula that sits there for 3 days. There is a straight in one which always gets bent in my bag, but that's this one there, these two here in the middle, so you might be able to just see, normally that's straight down, not bent. Somewhere between 8 to 10 mils usually in length. And there's a metal one. I've taken the steel needle off for safety, but it's about the same length and width as the little Teflon cannula, which has a remote disconnect site as well. So people choose which one they want. Angled is really good for lean people because you can put it in quite shallowly. And if they're very active, it anchors a lot better than the ones that are straight in. It's easy to accidentally pull them out if they're straight in. And that one is usually put in manually into the abdomen. These two come with inserting devices like this little thing here, which just pops it in for you. So you'd hold it against the abdomen, squeeze some buttons, and it pops it in. And so it's really easy to use, but it is easier to accidentally pull out. The other nice thing with that is that you can just pop it around the back of the hip and just squeeze those buttons on the device and pop it in and give the tummy area a bit of a rest, which is quite good because a lot of people get overused sites on the abdomen, or they find that the sites are more prone to fall out because of twisting and bending, or picking up small children, and popping it around the back is quite a good option out of the way. And it's an area that's less used, so less prone to lipohypertrophy, which is one of the advantages with the metal one here. Really easy to just pop it in like a thumbtack, and because of this remote disconnect site there, it means that they're not having to reach right down behind to reach it to disconnect. They can disconnect from the side, so it's a little bit easier. They don't have to be a contortionist to reach it. So those are essentially the options, 3 types, and they come under different names according to which pump, which always makes it slightly confusing if you've seen the prescription forms with those screeds of names, but essentially it's those 3 in different sizes. So I've really mentioned that. So as I was saying, most people will put their cannula sites into their abdomen because it's easy to see what they're doing, especially when they're learning. It's best to be using the abdomen, but it's really important that they're rotating over a broad area of abdomen using their sides so that they don't develop lipohypertrophy, which can develop really quickly with cannulas because you're leaving them indwelling, compared to lipohypertrophy that can develop with over-injecting into the same site. So rotating is really important, and using the back of the hips is a really great alternative, which is what that one in the corner is trying to show. Some people use thighs. It's not often used, but it seems to work. I haven't seen it in promotional or pump information booklets as a site option, but people do use it, and if their blood glucose levels are unaffected by using the thigh, then that seems to be a good alternative. People are also very good at hiding their pumps away. Women in particular seem to tuck it down in their bra. Sometimes you see the little telltale loop of line popping up. They'll often use a garter belt as well if they wear skirts or dresses, but most people would just pop it into a pocket. And quite a few use these belts, particularly at night for sleeping, so that it's not they're not sleeping on top of the pump, which is not a problem, but some people just don't like the idea of lying on top of their pump, or if they toss and turn a lot, getting all caught up in the line. And there's also other accessories that both pump companies sell for storing and protecting pumps, like that little backpack kind of thing for children. So what can a pump do? I mentioned earlier that essentially it's mimicking release of insulin from a healthy pancreas. So that's what this diagram here is showing. And you can see that the spurts that correspond with a meal, spurt of insulin is known as a bolus, and in between times the pancreas is just releasing a constant trickle of insulin 24 hours a day while you're awake, whether you're sleeping, between meals, and that's just to keep the brain and the nervous system functioning and prevent the liver from releasing stored glucose, and that's basal insulin. So essentially that's what we're trying to mimic when we're using multiple daily injections, or MDI, and also trying to mimic that with a pump. the problem with multiple daily injections is it's not terribly flexible, and despite our best efforts, or a patient's best efforts with adjusting doses, you can't adjust for the fact that the background, usually lantus, is very flat and is not, you can't manipulate it to fit, say, a rise like this, which is very common towards dawn, the dawn hours. Insulin requirements often increase, and so people will often wake with a very high fasting glucose, having gone to bed with a perfectly normal blood glucose, and wonder what's going on. And it's because the lantus can't meet that variability in insulin requirements. And so that's where a pump does have the advantage that you can manipulate the dose by having an hourly rate so that you can adjust it to fit an individual's insulin requirements. And, missing a slide, never mind, but not everyone has this profile. This is a common one, but it's not everyone. Everyone will be slightly different, so it takes a little while to work out what their individual requirements are to get that best fit with a pump. So how does the pump mimic basal insulin? So it delivers rapid-acting insulin continuously, 24 hours a day, and so that essentially does away with the need for lantus. And it can be manipulated by putting in an hourly rate. So most people would have between 4 to 8 different rates, basal rates, on a pump, and 1/20th of that hourly rate is delivered every 3 minutes. So it really is mimicking the way a pancreas releases insulin. That rate will be varied according to the individual's insulin requirements, and we only find that out through a lot of testing, including through the night, to find out what their actual insulin requirements are so we can get a good fit. And that's where things like continuous glucose monitors are really helpful, so they're not having to wake up and test through the night. The continuous monitor does that for us, so it's very useful. And in that way, we can hopefully end up mimicking what their insulin requirements are with a pump. Oh, this is the diagram I wanted. So this one is showing a very typical pattern of basal insulin levels typically tend to drop quite low overnight, so from about midnight to 2, usually most people, but not all, their insulin requirements are at their lowest, so require the least amount of insulin. And then towards dawn, as the morning hormones start to kick in, insulin requirements increase. And lantus always has to be lowered to this point to avoid overnight hypos, but it means that you're going to get this escape high blood glucose level because you're not meeting insulin requirements in the morning. So with the pump, you can set a rate that is lowest between those hours, and then you can increase the rate to adjust for the increase in insulin requirements in the morning. But again, not everyone follows that pattern. Some will do quite the reverse. That's just a common one. To deliver a bolus, this is done with the buttons on the front of the pump, and basically the patient would just, using these arrows and the OK button, key in an amount. And that amount they work out through carbohydrate counting or working out a correction dose. So to cover carbohydrates, they use an insulin to carb ratio. So you might see something like 1:10. What that means is 1 unit of insulin will cover 10 grams of carbohydrate. And if their blood glucose levels are running a little bit high, then they would use an insulin sensitivity factor. So if you see something like ISF of 3, what that means is that 1 unit of insulin will drop their blood glucose level by approximately 3 millimoles. And really, this is the key to successful pumping. This is where, once you've got that basal rate right, by mastering this, they can get really great control. But it's not easy. So they have to learn quite a lot. So in this example here, Flossie's got a fairly large lunch appetite, and she uses a ratio of 1:8, meaning 1 unit of insulin to every 8 grams of carbs. So Flossie needs to know in her lunch what parts of her lunch or what items contain carbohydrate. She needs to know how much carbohydrate is in each of those items. So she either needs to learn that through practice, or she can look it up in a little booklet or use websites, apps. So she needs to be fairly competent to work that out. And she wants to be as accurate as possible so that when she applies that formula, which will be, in this example, 84 grams divided by 8, she would take 10.5 units of insulin. So if she hasn't calculated that accurately, she could be quite off with her dose and either over or underestimate the dose, which is going to lead to problems with hyperglycemia or hypos. The other thing, of course, is that she can narrow that down to quite a precise dose. So if that had come out at, say, 10.25 units, she could in fact give 10.25 units, which again improves the accuracy. But if she doesn't quite get it right, she might have underestimated the carbs in her lunch, or she may, her basal rates might not be quite right in her afternoon period, or maybe she had a stressful afternoon because she was presenting to a large group and her blood glucose levels went up. Then she could apply a correction formula like this. And this is current blood glucose minus a target, which is usually between 6 to 8, divided by her individual ISF. So again, she needs to be fairly competent with using maths, using a calculator. So in this example, imagine that 3 hours after lunch, her blood glucose level is 14.7, her ISF is 3 and her target is 7. So she would plug those numbers into that formula and it would come out and tell her she needs a 2.56 unit correction, which she can then just dial up on her pump and deliver. So just through practice, we've learned that it's really important that pumpers learn to do this manually before programming it into their pump. It's really important that they understand when they're doing a calculation that if it doesn't seem quite right, they'll double check it. And by doing it manually, they get a feel for that. It's a bit like learning your times table before you use a calculator, because you'll quickly know when you've made an error. Also, if some pumpers like to take a pump holiday where they might just take their pump off for the weekend, or sometimes if they go away on holiday, they like to just remove the pump and go back to pens. Or if they have a pump failure or a pump malfunction, they need to know how to revert back to doing these formulas manually without it being too stressful. If they've only ever used the pump, they're in chaos. They don't know what to do if the pump fails or they can't use the pump. Having mastered it manually, then you can program that insulin to carb ratio, that ISF, into the pump, and then the pump user just needs to enter their carbs and the pump will work it out for them. Having done it manually, they'll think, yes, that sounds about right. Push OK, and away it goes. The pump also is pretty clever, as it can keep a track of previous boluses. So it will know if there's still insulin from a previous bolus that's still active, and will subtract it from the bolus that the patient is about to give. So it's pretty smart. The pump user, though, can still override that. They might want to increase it because they know, for example, they're a bit stressed or they're feeling ill and they know the insulin requirements have gone up. So they can use a temporary basal increase for a period of time, or they can do the reverse, decrease the insulin that's being delivered for a period of time because they might be physically active, for example. Again, continuous glucose monitors are really helpful with teasing out the exact requirements, individual requirements. However, lots of good things, but it is just a tool and it's only as good as the patient's ability to use it. The pumper really needs to be thinking like a pancreas, knowing situations when their pancreas would normally be producing more insulin, when it would be producing less insulin, how much less, for how long. They really need to be thinking along those lines. They also need to be testing a lot and recording a lot and then analysing those results so they can make little changes. So it does require a lot of motivation, perseverance, record keeping, which gets very tedious, and a willingness to work closely with the diabetes team who will help them with this. So you're probably starting to think, gosh, why would you use a pump? Because it seems an awful lot of trouble and a lot of effort. But there definitely are some advantages. It can improve blood glucose control dramatically, and in doing that, it often improves patients' quality of life, and feedback we often get is patients saying to us, I feel like I've got my life back. First time since I've diagnosed, I feel like a real person again. So that's really kind of makes it all worthwhile. By getting rid of lots of hypos or severe hypos, it improves their hypo awareness. And by having improved control, it also helps prevent or reduce the risk of complications. And in some cases it can reverse it, like retinopathy with good control can sometimes be reversed. It certainly means that they have a lot more flexibility with lifestyle. They can skip meals, delay meals, they can exercise more confidently without fear of hypos by using those temporary basal features. And it's really helpful for children or for adults who are on really tiny doses of insulin, because they can now deliver those tiny doses, whereas on pens the smallest they could ever give was half a unit, but on a pump they can give 0.025 as basal or 0.05 as a bolus, which makes a big difference. So again, it really does have that potential to mimic insulin release from a healthy pancreas. But of course there's the drawbacks. It is a steep learning curve. There's a lot to learn, and it does take weeks to months to master it and to get it a good fit, if at all. A common fear is people don't like the idea of being attached to a pump 24 hours a day. And that's probably one of the biggest things we hear from patients who are considering a pump, is the thought of being attached to this thing 24 hours a day. But most people, after the first weekend of being on a pump, that's not an issue anymore. It doesn't bother them. They're starting to see the advantages of it. Because of that indwelling cannula, there is an increased risk for site infections. So hygiene, good technique, really important. There's an increased risk of diabetic ketoacidosis, because remember the pump has only got rapid acting insulin in it, and if there's any disruption of delivery to the site, and usually it's a site issue, the cannula has become blocked or dislodged, or they've left it too long and the tissues are starting to swell up, so they're not absorbing the insulin. It means that once that insulin has worn off, so it has an action time of up to 4 hours, they can start developing ketones very rapidly, because there's no background long-acting insulin with a pump. So that's one of the biggest risks. It also requires frequent testing of blood glucose levels, checking for ketones, recording, analysing. So it's not suitable for all type 1s. There is a select group who do well on pumps. And improved blood glucose control cannot be guaranteed. So it is important to be selective about what patients are suitable for pumps. And we do see people who do just as badly on pumps as they were on MDI, multiple daily injections.